All right, good morning, everyone. As we said, we're going to switch gears a little bit and talk about some ocular ultrasound this morning. Unfortunately, I have no financial disclosures, but hopefully at some point we will. We are going to talk a little bit about what makes pediatric ultrasound a little bit different than adult optic ultrasound. It's widely used in the adult world because it's so feasible and it's easy to get a picture, but pediatrics has met some roadblocks. So we'll talk about why that is, and then we'll talk about some indications for ultrasound, mostly in an acute setting for the ED and the PICU, but knowing that this does not talk about the wide use in the outpatient setting as well. All right, just to kind of orient everyone here, we have the anterior chamber here, and then this hyperechoic line here shows the iris, then the lens, and then we have the posterior chamber here moving into the vitreous body, and then the retina, and then not pictured in this particular image will be the optic nerve sheath, which we'll show a little bit later. And then that'll kind of be our starting point. Moving our equipment here, what we really look for is moving and meeting the pictures of Alara. So because these pediatric patients have our moving and growing tissues, we want to make sure that we are particularly sensitive to these tissues, but we do realize that we need to get our crisp, really high resolution images. So we want to make sure we have our high frequency transducer, usually at least above 7.5 millihertz, but a lot of studies have been done above 10 millihertz. And then we want to make sure that we are particularly sensitive and protective and low risk when we're getting these images. So it's been described that we use thermal indexes less than 1, making sure that with this acoustic energy that is being formed with the ultrasound, that we are being protective with the tissue heating, and then with the mechanical ultrasound we are less than 1.3, though a lot of different presets that you will see that come with these newer ultrasounds is less than 0.7, and that's making sure that with the ultrasound wave that's being formed, we're making sure that the gaseous movement doesn't cause any harm to these very delicate tissues that we have. You will see a GE probe that I pictured here. We happen to use these in our PICU, but there is no better use than any other probe. We just happen to use them. A lot of times we're going to use the L412T, but you can get them, those images for babies under 5 months. It just becomes technically challenging, so you can use the smaller probe. So that'd be the L4T22. We're going to start talking about the optic nerve sheath diameter. I told you I was going to get a better picture of this, and here you can see this is your posterior chamber and your globe, and then you're going to see this hypoechoic structure here, and this is going to be your optic nerve and your optic nerve sheath. For your measurements here, we're going to be getting your same kind of technique, I guess, as your adult. You're going to measure 3 millimeters behind your retina here, and then you will go and get your measurement of your optic nerve sheath. The great thing about optic nerve sheaths is that they're contiguous with the CNS and they're distensible, which means that any increase in your intracranial pressure, you're going to see shown with your optic nerve sheath. So it's kind of like a window into what you're seeing with the pressure into your brain, which makes them perfect for indications for any intracranial pressure, but we've seen them used for traumatic brain injury, intracranial hemorrhage, DKA, or any other metabolic failure and changes, hydrocephalus, and intracranial lesions. What does become quite difficult and tricky, and where a lot of the difficulty has come with the research in optic nerve sheath diameters in pediatrics, is that it has become very difficult to find normative values for the different age cutoffs. And anyone who has been very familiar with this research has seen that there is different age quartiles that have been used, different cutoffs that have been used, and it's just very difficult to see where these normative values lie. over far to your right, you can see that the adult seems to be fairly well recognized, that your normal values are about 5 to 6 millimeters. So you could with fair confidence say that if you have if you have like a less than 10-year-old and you have like a 7 millimeter optic nerve sheath diameter, that is grossly abnormal. But then the question comes, if you're kind of in that gray zone and you're in the like 5.5 millimeters and you've got a 4 or 5, 6-year-old, what do you do with that kind of information? I'll talk a little bit more about that. But the question would be like, well, why is that different? Why is that different for pediatrics than adults? And part of that comes because their globe size and their head circumference is changing as they're growing. So this is a great picture that Grudnall did from the Survey of Ophthalmology, looking at globe size as we're aging. As you can see, from 1-year-old to about 3-year-old, there's like an exponential growth in your globe size, which makes it particularly difficult to find a normative value, especially as these kids are growing. And you can see that this is also changed for your head circumference size. And this kind of leads to the question, is the optic nerve sheath diameter better described per patient, kind of based on these other measurements, excuse me, rather than kind of like a range, a normative range. And then these are great examples of distended optic nerve sheath. As you can see, these are really great pictures because you can see the whole globe. They're on axis, meaning that this optic nerve sheath isn't kind of way over here when you have the rest of the eye lined up. And then you can see the exterior and interior diameter, exterior being here, interior being here. Right now, all the literature is kind of pointing that we're going to measure the exterior diameter at this moment, but making sure that you can see both diameters, meaning it means that you have a nice head-on view of your axis and you're not like getting an off-axis cut. And we'll talk about a little bit why that matters. But as you can see here, this is a 13-year-old Tylenol ingestion, and their diameter is about 7.8 millimeters. So that's really quite a large diameter, even for an adult. So you could seeing this picture, feel pretty good that their intracranial pressure is raised. And then same thing for this picture on the right. For a TBI patient, that their diameter is also raised to about 5.8. And this is a little bit where it gets into the gray area when you don't have the best normative values. Because if this was just a pure adult, you could say this might be in the range, but this is important for pediatrics to have their normative ranges being that this would be a sign of increased intracranial pressure for this child. And then moving on to another good indication, a good use of ultrasound for the ocular ultrasound is pupillary reactivity. So especially in the ICU, we have a good handful of children that come in who just have really severe edema, really terrible burns, just really bad trauma, when there is no way that we can get a direct visualization of the pupillary reflex. So this is a nice way to be able to make sure that we have good pupillary reactivity. So the way that this image is obtained is that the probe is placed on the eye, and then the lights are turned on and off like you would normally getting your pupillary reflex. And this is a good example of a pupil that is constricting nicely and has a good reflex. And then this is used quite a bit in the ED as well for our trauma and our retinal detachments. I'm going to focus mostly in the posterior trauma or chamber, excuse me, mostly because the anterior trauma is used mostly by ophthalmology. You can see your lens dislocation, your foreign bodies, your globe ruptures, and there is a really nice paper a systematic review that was done by Propsy, Krishner, Strachan, and all, that kind of described the sensitivity and specificity of looking at all of these different findings while in the ED. And this was done by just providers that had regular training in optic ultrasound, and they showed a really nice, excuse me, sensitivity and specificity, especially for the intraocular and globe rupture, with low risk of bias that was almost at 100% for both of them. So this was a great use of ocular ultrasound to get treatment as fast for these patients as possible. And then looking at vitreous and retinal detachment. Vitreous detachment, you're going to look at this optic disc here, and you are not going to see, you're going to see a serpentine, which you can kind of see here, but it's not going to be attached to the bottom of this disc. It's going to be floating kind of up in this posterior chamber. It's going to look like a snow globe kind of picture, and it's going to cross midline. It's going to just kind of look like it's floating in your screen, as opposed to the retinal detachment, which is better pictured in this screen. You're going to see this kind of serpentine picture of the retina here. It's going to still be attached to your optic disc, and it's not going to cross midline. And the whole appeal of optic ultrasound is that you're able to catch these findings sooner, able to get ophthalmology sooner, because I'm sure a lot of us have found that, ophthalmology, while they're easy to come in, they're not always available as soon as we might like them. And that systematic review also showed that with the retinal and vitreous detachments, that sensitivity and specificity was also still good. It was 0.94 and 0.93 of the low risk bias, respectively. So I think this shows that even with trauma and retinal detachment, the ocular ultrasound really has a good place, and it is well used by providers who are not ophthalmologists. And then going into the literature summary, which is where this gets a little bit difficult, mostly into the optic nerve sheath. There have been a lot of reviews looking for normative nerve sheath diameters, and then also looking for its where it coincides with increased intracranial pressure. There have been a lot of people looking for where those age quartiles best kind of break apart. There have been people looking to see where these optic nerve sheath correlate with intracranial pressures above 20, really looking for where we would normally look to intervene clinically. And it has been difficult to find a consensus with that. So we have a lot of meta-analysis that are really trying to find a consensus for how do we use all of this information clinically. It's a good tool that we have at our disposal, but we want to find a way that we can use it for our patients in the pediatric world, that it's going to really clinically make a difference. And that's kind of almost the standstill that we're at. There is a nice consensus for the adult world that really talks about the like how to get the imaging, the equipment, all of those, which a lot of that does transition to the pediatric world. It is where our cutoffs, and that's kind of where we land in. So we'll move into the limitations here, and I'm going to use myself as an example because I came as a very novice obtainer of these images. And as you can see, this is a 4-week-old who is very much awake. And these are two of my better images as I was first obtaining these. And you can see that it's very easy to get these optic nerve sheaths that are just slightly off kilter, and off kilter meaning that the axis is not perfectly straight in line with the rest of your globe. And when these patients are so young, the accuracy of your measurement is going to be just a little bit off. But when you're talking about 2 or 3 millimeters, in that range being so small, that can actually be quite significant in this. So that kind of goes that there is that large implication in technique. So while it's easy to get a picture of the eye, it is much more difficult to actually get a good, well elucidated image of the eye, which kind of nicely turns into where are gaps in optic nerve and ocular ultrasound. So one of our big gaps is there is a well-described change in normative values with our head circumference and globe size of our eye as we grow. So does this mean that we just don't have a great idea of the gaps yet? Or more likely, does this mean that this measurement is going to be more of a personalized measurement per patient rather than an age or a variable gap. And then the other question and a gap that we have is that we do not know the plasticity of the optic nerve sheath. We know it's dynamic, but we do not have the best idea for how long it's distensible for. So can we get this, like, how long does it stay distensible for? So how quick, like often can we get these measurements for? And then for clinical use, this shows in for education, there's a lot of good education about how to get the images, but I don't feel like there's a great almost warning. That seems a little bit harsh, but about we really need to make sure these images are on access, need to make sure that we can see like inner and outer sheath, just to make sure, especially in pediatrics, that we have a good and accurate measurement of the optic nerve sheath. And I think all of this kind of comes down to a bit of hesitancy in clinical use and to use it by itself. To just look at whether we have increased intracranial pressure. So I think to be able to do that, there is going to have to be a little bit more of rounding up and some research for these topics. I wanted to really thank Dr. Zoika and Dr. Sorwell for images and for helping me and allowing me to talk here, and then Dr. Riggs and Dr. Bhargava for helping me and teaching me all I know about optic nerve ultrasound.